Hey, and I was going to talk to you about chest X-rays. And the question I have is, can you look at this X-ray? Because you get asked that a fair amount when you're an intern and a resident, not just in the ICU, but sort of all over the hospital. Okay, so some disclosures. I'm not a radiologist. I do look a lot of chest X-rays and chest CTs. I'm a VA intensivist. I have no financial conflicts of interest. I used a bunch of slides from Andy Lux, Julie Takasugi, and Bashak Sharu. This lecture has been given many times in many different forms by these people and myself, and there'll be many iterations to come in the future. But I'm focusing mostly on ICU films, so I'm not going to talk about like lateral films as much, but those are also really useful. But we don't see them too often in the ICU. Okay, so the objectives today. We're going to talk about just some chest X-ray basics and the approach you might want to take to look at a chest X-ray, kind of a thorological approach. We want to talk about how to locate and describe opacities, and then we'll spend some time looking at can you use this liner tube, which comes up all the time when you're in the ICUs and the floors. Okay, the first lesson of radiology residency, and for you guys, is to avoid the satisfaction of search, which is basically radiologic premature closure. So you see one thing that's very dramatic on an X-ray or a CT scan, and then you basically don't realize that there's other stuff going on that you might miss and other diagnoses that you might miss. This is how radiologists might get sued, basically. So you want to use a systematic approach when you're looking at a film, and we're going to talk about the chest X-ray systematic approach for this particular talk. So step one is to make sure you're looking at the right date, name, and time. And this gets you mixed up all the time, actually, especially in this computer system where you can just pull up films very easily. You might have a chart open and pull up a film for somebody else that you don't mean to be looking at, or are not going to help you make a diagnosis on this patient that you really care about. So anyways, the sub I asked you a question, you're sitting there. The read doesn't say anything about pulmonary edema, but I think the film looks like pulmonary edema. What do you think? So this is the first poll. Is this wet or not wet? Please vote.
All right, we got about 20 responses, so I'll show you the results.
Awesome. So it looks like most of you said wet, about 70%, 14% said not wet, and 14% said don't know. Okay, we're going to get back to this one, I swear. Okay, first some chest X-ray basics. I think before you even go into your systematic approach, you actually have to decide if the film is a good and useful film. And I use the RIPE mnemonic to decide that. R is for rotation. Is a patient rotated? I is for inspiratory result, how deep of a breath they're taking, because that affects the film. P is position, whether they're supine or upright. And E is exposure. So all those things kind of factor into sort of how you interpret the film. So rotation. I use the clavicles to decide if my patient is rotated or not. And this chest X-ray, the patient is pretty much not rotated. These spinal processes here are kind of right in the middle of the film, and the trachea is sort of right on top of these spinal processes. This trachea is this hypolucency right in the middle here. The clavicle heads are pretty much equidistant from the spinal processes and the trachea, and they're sort of equal kind of in where they are located. Now compare that to this patient, where here are his spinal processes. It's actually kind of hard to see the trachea in this one, but I would say it's where the tracheostomy tube is. So this is where the tracheostomy tube is, and you can see that the tracheostomy tube is not in front, right directly in front of these spinal processes. And this clavicle head is right kind of above the at the trachea. This one's sort of farther away, so this patient is definitely rotated. Okay, inspiratory result. So basically, this is where you're counting ribs to see if the patient took a deep enough breath. And the goal is 10 ribs. The problem is that the first two ribs are really hard to see. So the first rib actually, so these are all posterior ribs that we're looking at. If you look closely, you can see the anterior ribs kind of going diagonally, but basically when we're counting ribs, we're counting the posterior ribs. And the first rib sort of curls around like this and kind of is just is there. The second rib is just right at the top of the thorax from this chest x-ray view at least. And then the third rib is really the first one that's most obviously a rib, I would say. So basically when you're counting, you can sort of start counting this rib as number 3, 4, 5, 6, 7, 8, 9, 10. And usually about 9 or 10 is a good inspiratory result. All right, let's get back to this case. I forgot about it. Let's count the inspiratory result here. So this is the first rib is going this way. The second rib is here. Can you guys see my cursor, right?
We do see
Okay,
your cursor.
awesome. So third, fourth, fifth, sixth, seventh, eighth. The same patient took a deeper breath next time, and you can just see what a big difference it looks like in the parenchyma. So when the patient really inhales, fills up their lungs, the parenchyma doesn't look nearly as busy. You could argue, I think, that there's some cephalization here and that my patient might be a little wet. I would say it's a little bit less clear, I would say. The teaching point here is that it's less clear that the patient's got pulmonary edema when the patient actually takes a good inspiratory result. So he has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, pretty much. So that's why that inspiratory result makes a big difference for whether or not the patient took a deep breath. Okay, whether or not the patient's upright or supine can also make a difference, especially with a lot of pleural fluid, pleural effusions, pneumothoraces, that type of thing. And so there's usually signs on the X-ray about what the patient's positioning is. Sometimes it'll just say upright or supine. Sometimes there'll be arrows pointing up, so the patient's upright or down. I don't know if you see these too often anymore, but these are called inclinometers. And the more balls that are down, basically, the more upright the patient is. So this patient is more upright, this patient is less upright. And then nowadays also you'll see these circles with some little marbles or BBs in them, basically. And if the patient's lying flat, those kind of ball bearings will be right in the middle. But if they're sitting up, those are going to fall down to the bottom. So that makes the patient, you know that this patient is more upright. Okay. And then penetration. So this would be an underpenetrated film and it makes it look very busy. I don't have a comparison for this particular patient, but you can just sort of see how everything is very accentuated in terms of the vasculature on this patient. Probably a more appropriate penetration is in this film, which is also pretty busy, but you can actually, the goal is to be able to barely make out these spinous processes right behind the heart. And you can sort of see the outlines of the spinous processes, hopefully. Okay, so that's exposure. All right, the same subject comes up to you and says, why does the heart look so big in this film? And they compare it from an old one. So what's going on here? Why is this film, the heart looks smaller on the same patient than this film? There's some pathophysiologic explanations for that, but I'm really more thinking about whether or not the film is PA versus AP. So generally in an anterior posterior film, which is what we pretty much get the majority of time in the ICU, and these are the portable chest X-rays. We're shooting from the front, and then kind of that makes the heart look bigger compared to a PA film, which is shooting from the back. And this sort of diagram sort of explains that a little bit better. So you see these machines all the time on your inpatient rotations or in the ER. They'll come down, and they'll be this kind of attached to the machine, and they'll put a plate behind the patient, right? And so with the image beam coming from the front, the shadow of the heart makes a pretty big shadow on that plate. But if the patient's flipped over, and usually this is how they shoot the PA films, right? Or this is the definition of PA, posterior anterior. That heart is farther away from the beam source, so it makes a smaller shadow, and that's why the heart looks bigger on AP films. One other thing, you can usually tell a difference between PA and an AP film by where the scapulas are. So in an AP film, usually the scapulas are seen within the chest here and here on this film. Whereas usually for PAs, the patients are sitting kind of more with their arms forward, kind of almost hugging the plates basically. And so their scapulas kind of move out of the picture, which allows you to see the lung parenchyma a little bit better up on these apices. This is another reason why the PAs generally give a better picture, but they're just hard to get because the patient actually usually has to stand up for those PA films. Whereas in the ICU, they're all kind of in bed, or in the ER, they're all in bed. And so you're just putting a plate behind them. Okay, so just a few more things, just a review. Before even interpreting the film, really, you want to make sure that you know that this is the patient, time, and date you're looking for. The films are ripe, and then you want to know if it's an AP or PA, and if the patient took a good inspiratory result. Okay, the systematic approach that I learned, and I think a lot of you learned, is the ABCDEF approach to sort of looking at the film, going from so that way you make sure you hit sort of the main things in the chest X-ray. So starting with airway, whether or not the trachea is deviated or narrowed, bones and soft tissue. This is where you might be looking for fractures, but also remember the soft tissues, right? And the subcutaneous emphysema is one thing you see with that, but other things as well. You want to look at the cardiomediastinal silhouette and whether or not it looks bigger or smaller. And remember, comparing apples to apples, so AP films to AP films versus not making too big of an assumption with the AP versus PA. Sometimes the mediastinal lymphadenopathy will affect that, the position of the diaphragm and what the diaphragms look like, everything else. So that's positioning of lines and tubes, and then the lung fields themselves. And so what the parenchyma looks like, if there's any pneumothorax, etc. In the ICU, a lot of times the attendings will ask you to comment on the positioning of the lines and tubes before you go into this A, B, C, D, E, F thing. So it depends. So that's one thing that you might hear. Okay, so just kind of going through the A here, airway. These are examples of kind of you're gonna see pathology right away if you focus on the airway. This trachea is deviated probably because of a something going on right here, and then this trachea is probably a little narrow. Usually it's a pretty straight parallel line, but this one sort of bends in the middle. And one in this case, in the case on the left, the trachea is deviated from a large thyroid mass, and on the right, it's from lymphadenopathy, kind of impinging that trachea. So bones and soft tissue. I'll give you 5 seconds to see if there's any bony abnormalities on this film. And yeah, I think it's probably smart to look for the pathology here, but then you'll soon pick up this, right? These are rib fractures. And anytime you see an effusion, or kind of what this is a meniscus that's part of an effusion, and rib fractures, you got to think about a hemothorax. And these actually come up a fair amount in the IC or in the VA. These kind of patients present a fair amount where they have fallen 2 weeks ago and they feel like crap, and they come in and they've actually got blood in their thorax from that fall. It's just old now and been sitting there for a while. All right, cardiomediastinal silhouette. This is not the greatest film because it's actually hard to see the trachea and it's, I think, a little bit underpenetrated, but the mediastinum is definitely remarkable in this film. Mostly because it's wide, right? So this usually there's if you see the trachea, then you see just a very thin line, then you see the lung. And here you see a bunch of white basically, and I think this is where the trachea is in this film. And so this is why we get chest x-rays for people with chest pain, because we want to see if they have a widened mediastinum, because then we might start thinking about aortic dissection. This is one of the reasons we get a chest x-ray, I should say. But there's other things, right, besides aortic dissection, like lymphoma, mediastinal mass. Actually, patients who are taking a deep breath can make this kind of mediastinum look wider as well. So if a patient doesn't take a deep breath, and then the diaphragm, this is where sort of the supine and upright kind of make a difference too. This patient is more sitting upright, and you can see that the fluid. This is an effusion, so you lose the diaphragm, but you see kind of a meniscus of fluid sort of layering below the lung. In this film, you lose the diaphragm too on the right, but that's because the effusion is all sort of layering behind the patient. And that's when they're supine, this is sort of how a big effusion oftentimes looks, where it starts out very white and then it becomes less white as you go up. So effusions can look different if you're upright versus supine. Okay, so 3 abnormal findings in this film. Can someone spot, or I'll give maybe everyone about 10 seconds to see if they can find abnormalities in this film. Okay, so starting with airway here, It looks a little bit deviated. That's actually not that big of an abnormality, I think, compared to some of the others. If you go to bones and soft tissue, right here, this is abnormal, right? You should basically be able to see the shoulder look pretty normal. Yeah, there's definitely something going on with the shoulder. There might be a dislocation as well, but I think that the loss of any bony mass here, or the spicula or the bone here, is abnormal. Um, the breast shadows, right? There's a breast shadow here, but there's not a breast shadow here. And actually, with this lack of breast shadow and these little clips here, you can pretty much diagnose this patient as having a former mastectomy and probably breast cancer. Yeah, exactly, a left mastectomy. And you worry with this type of bony abnormality that this patient has metastases to that bone. I would say a third abnormality would just be that this parenchyma, especially down here, looks a little busy. And so these sort of interstitial opacities sort of is what I'm talking about as a third abnormality. Okay, so let's talk about locating and describing opacities. You'll see what I mean when I say locating, because your attending is now talking to you for some reason, and he wants to know what lobe that pneumonia is in. And how are you supposed to know that? So let's see what you guys think. Okay, how's the poll going?
We are good. I'll close it.
Okay, awesome. So 67% said right middle lobe and 33% said right lower lobe. So two-thirds, one-third. Excellent. Um, yeah, so this is where we'll talk about the silhouette sign. So the lung and the heart have different densities, right? The heart is a lot of soft tissue and the lung is a lot of air with a little bit of soft tissue. And so they'll see the lung will be more lucent and the heart will be more opacified, basically. So you can see a clear border in between those two. When you lose that clear border, it kind of you can that's called the silhouette sign, and that usually means there's something going on there. A lot of times that kind of loss of the border will be kind of a big white blob, right? But sometimes it will be a little bit more subtle than that. And so just anytime that that border is lost, you should sort of think to yourself, something is going on with that area. So the opacity has the same density as the heart, so there's no longer this clear border between the structures. So going back to this film, I would say that this right border here of the heart, this right heart border, is pretty murky and lost, and so this is probably a right middle lobe pneumonia. And why do I know that that's a right middle lobe pneumonia? This is where sort of these radiographic landmarks are helpful, but basically the right middle lobe sits anteriorly, and that's also where the right heart's border sits anteriorly. The right lower lobe is more posterior and kind of sits right above the diaphragm. So anytime this right hemidiaphragm is lost, that's a right lower lobe, something going on in the right lower lobe. This is the paratracheal stripe. This is sort of what I look for most when I'm worried about a widened mediastinum. See on this film, it's like nice and tiny. Um, Kind of want to point you guys out this D here. This is the azygos vein. It's a little vessel that sort of sits where that right um, main stem comes off the carina. And this vessel can sometimes be bigger, especially in states of volume overload. So sometimes you can actually spot if a patient's sort of in a little bit of CHF, if that azygos vein is dilated. This is the aortic knob. So the left heart border is anterior again, and the part of the lung that sits anterior on the left side is called the lingula, which is a part of the left upper lobe, but generally we kind of call it the lingula. In the pulmonologists refer to it as the lingula. And the left upper lobe is going to be sitting up anteriorly, kind of against the trachea and this aortic knob, and so that's where these might be silhouetted out in those types of opacities. And then finally, the left lower lobe sits on top of the diaphragm and also retrocardiac, right? So this loss of the retrocardiac space or this loss of this aortic stripe as sort of where you might find left lower lobe infiltrates. Okay, so where is this one? Okay, looks like 11% left upper lobe, 72% left lingula, and 17% left lower lobe. Yeah, I think this one is making this left heart border shaggy enough that I think this is with a lingular effusion, or I'm sorry, a lingular opacity. Um, okay. All right. What's wrong here? This is a different sort of discussion. What is wrong with this particular patient? I can give you guys a little bit more time on this one. Okay.
Okay, I'm giving them one more second.
Sure.
Okay.
All right. This is great. Status post right lung resection gets 29%, right pleural effusion gets 24%, right lung collapse gets 43%, and not enough information gets 5%. Great. So we ended up getting a CT scan on this patient, and this is what we find. So this is all fluid here, and it's really causing a lot of atelectasis with this right lung, but this really the fluid is the main thing the main phenomenon that's going on here. So this is a situation where you've got a whiteout of one lung, and to decide what's going on with the lung that's whited out, you kind of have to look at the trachea here. And so the trachea in this case here, in our case that we presented, and this other patient here, is deviated away from the white lung, right? The whited out lung. So that usually means that there's some sort of space filling fluid or space, something filling up this thorax that's pushing everything to the other side. So it's off of midline going in the opposite direction. So massive pleural effusion, the trachea is deviated away from the opacity. So when a lung collapses, and what I mean by collapses is what's called lobar atelectasis. So when some sort of mucus plug or something gets in the airways, suddenly all that air kind of leaves that lung and the lung collapses on itself and it's just sort of atelectatic tissue. That sort of means that there's going to be a loss of volume. And so the trachea is actually going to go towards that loss of volume, and kind of be deviated in the direction of the opacity. And this is to the point where the heart is even moved over to that entirely into the left hemithorax here. So in lung collapse, the trachea is deviated towards the opacity. So when the lung collapses like that, usually there is going to be fluid associated with that because suddenly there's just nothing there, and so the body just fills that sort of vacuum basically with fluid. And so you'll see that there's probably, if you put an ultrasound to this, you'll see that there's a little bit of fluid surrounding this collapsed lung. But if you look at, I'll put an ultrasound of this, all you'll basically see is fluid, and you might see a little bit of tendrils of lung kind of in there. So whereas this one, the lung will be kind of right up against the ribs with a little bit of fluid around it. Okay. So with this one, you'll want to do a thoracentesis with the massive pleural effusion. With the lung collapse, usually what we do is say chest physiotherapy, let's have the patient cough. Sometimes we even do a bronchoscopy to get that mucus plug out of the airway so that suddenly that lung can refill up with air once we get the obstruction out of the way. Okay. All right, and then describing opacities. So these are kind of the two classic types of opacities here. This one is very like little clouds in the lung, little fluffy cotton balls filling the lungs, whereas this one looks like there's like lace throughout the lungs or a net throughout the lungs. And so one is the alveolar fluffy opacities. And if you say fluffy, that's fine, I think, when you're describing opacities. We'll appreciate that. And this one is sort of reticular, nodular, interstitial. So this is interstitial looking opacities. And those obviously can be two different, or these can be kind of different viruses causing different patterns, right? And different other things that affect the lungs causing different patterns. It's also useful to describe opacity sort of um, in terms of like whether or not they're unilateral, bilateral, whether they're peripheral or central. Different disease patterns will look more peripheral versus central. If you've got central opacities, that might make you think about cardiogenic pulmonary edema, for example. Focal or diffuse, that makes a big difference, right? And then the size. So basically, anything greater than 3 centimeters is equal to a mass, and anything smaller than 3 centimeters is a nodule. And then this also applies, all of these actually apply to CT scans, but the edges sometimes you can make out on chest x-rays, and whether or not they're smooth, irregular, or spiculated, right, might make you think about different pathophysiologies or pathologies. Okay, so just to summarize locating and describing opacities. So the silhouette sign helps us locate opacities. So the right middle lobe opacity can kind of muddy that right heart border. The right lower lobe will muddy the right hemidiaphragm. The left lingula can muddy the left heart border. And then the retrocardiac space can be lost in the left lower lobe opacities. The trachea can guide you to what's going on, whether or not goes in one direction or the other, and then use fluffy versus reticular kind of when describing opacities, along with kind of more general terms like bilateral, unilateral, focal, diffuse, etc. All right, now let's talk about lines and tube placements. Any questions so far? Or if you put some in the chat, maybe I can circle back to them after one or two of these examples. Okay, so how does the tube look? And by tube, in this case, I mean the endotracheal tube. So this patient just got intubated. Okay. Looks like 29% said too low, 57% said too high, and 14% said can't tell without calipers. Well, I like to use calipers. I think the tendency or the instinct, I would say, is to say, well, it shouldn't be this high because it looks a little high to me because it's by the clavicles. But the problem is that the clavicles can really be differently positioned depending on where you shoot the film from. So if the patient's too far leaning back, the clavicles might look lower in the chest. Whereas if you shoot it from more of an above angle, the clavicles will look very high in the chest. So the clavicles will move depending on where that is shot. The aortic knob here, which is this is what this is the aortic knob, with kind of the descending aorta or ascending aorta turning into the descending aorta. That's a pretty good landmark actually, and if it's right in the middle of the aortic knob, I would say that's good. But if I'm not really sure, I think really you want to use calipers. And most all of our X-ray software that we have now has the ability to kind of pull up calipers. And generally, you want this tube to be 2 to 5 centimeters above the carina. I mean, I'll also say that it's pretty hard sometimes to actually see this kind of where this carina is in the trachea. So that's something where you might have to look at it in a kind of play with the brightness or the contrast basically until you can kind of spot this. Okay, great. All right. can I use this feeding tube? We get asked about feeding tubes all the time as an intern.
We're getting some good results on this one.
Okay, excellent.
Okay.
All right, looks like 9% say yes and 91% say no. Yeah. it- oh, that is a no, actually. It basically, and we'll talk about this in a later slide too, but basically, you don't want it to make a turn before the diaphragm, and this might actually be going down the right main stem here into the lung. All right, what about this one? Okay. Yes, great. So yeah, I think this one is going straight down, and then once it gets below the diaphragm, then it deviates, and it's going kind of up, but it's not going up in a direction you want it. It's not going up in a concerning direction, I would say. And you could definitely know it's below the diaphragm. You see it pretty clearly here. So this is a good tube to use. Now, people argue about whether or not these should be all post pyloric or there's not really a lot of data that says that if you get a tube post pyloric, it prevents more aspiration pneumonias, which I think is the main concern with trying to get a tube post pyloric. Um, but there are going to be situations where you might want it to go post pyloric, and this is definitely not post pyloric because it's going in the opposite direction of your pylorus, which is sort of more around here. The other thing I would say is that it's really hard to actually tell, even if it goes in this direction, if it kind of goes down and then curves, right? It's still pretty hard to know that it's in the pylorus because the stomach can be really huge on patients. Okay, what about this one?
All right, we've got about 18 responses. Okay.
Great. Okay, awesome. 15% say yes, 85% say no. So yeah, I would argue no on this one. So the tube is here's the tube going down. It kind of curls around, but then it curls back up. And actually, it's curling back up in a direction I don't like because it's curling probably back up into the esophagus, and it's probably it might as you start feeding that, that's going to potentially regurgitate up the esophagus. And this patient, I think, actually aspirated this tube feeds is what's going on here. So it went all the way back up and then down into this right kind of main stem. So yeah, I think if it's going in this direction up, that's not something you want to feed the patient because the patient has a much higher risk of regurgitating that. If it's below that GE junction, I think you're in a better place. But you usually want it to be kind of more below, like we had in this last example, where it's several centimeters below that GE junction and not pointed up to the esophagus. Okay, great. One more. I think this is the last feeding tube one.
Whoops. Sorry.
Oh,
I think this one I might have accidentally missed on the
oh, that's okay. If you guys want to just say yes or no, a few yeses or nos.
Maybe a shout out from one of the party rooms.
No. People are saying no at Harborview.
All right. I'm gonna say that's a no as well. Let's see what happened here. We actually pulled that tube out, and this is what we saw. So this patient, this is a tough one though, right? Because it's definitely below the diaphragm, or it looks very below the diaphragm, but it's turning way too early, and you can actually even see it turn down the right main stem bronchus here. And this just gives you an idea of how posterior your lungs can go. Even though you've got your diaphragm here, you're still like there's still a fair amount of lungs in the posterior part of your chest that it can go to. And so this patient, we pulled it out, and it led to a bronchopleural fistula that we had to put a chest tube in for. So this is a diagram from I actually pulled from like a corporation that was trying to sell, I think, an AI thing, but it's I still it's useful for you guys, I think, just to think about kind of how just the placement. So these red lines, when your tube goes like this above the diaphragm, that usually means it's in the lungs. If it goes below the diaphragm, then turns, that's a good sign that's in the stomach. You don't really know if it's post pylorus until it makes this second turn here. That's when you know that it's post pylorus because that means it's turning in down the duodenum, further down the duodenum. And then this is you're probably not going to be placing the nurses are not going to be placing a bedside feeding tube this far down. But this kind of this turn here is what I use to judge whether or not it's out of the stomach. Okay. Um, what about this tube? Is this broken? Does this look okay? What's going on here?
Okay, I'm gonna give him another minute or so.
Okay.
This is a good one. Okay.
All right. 44% said it looks great, and 56% said call thoracic surgery. So this one, this is a chest tube. This is probably a surgical chest tube. It's pretty wide here. You'll see you'll see these surgical chest tubes most of the time in trauma patients, and then you'll see kind of more radio opaque tubes that kind of curl up into like what's called a pigtail. Sometimes you'll see those placed by IR or one of your pulmonary colleagues for kind of effusions or some pneumothoraces. But this is a surgical chest tube, and this actually is a normal part of a surgical chest tube. It's called the sentinel port, and it's basically the last port that's still actively trying to suck air or fluid, basically, or draw air into the atrium that this is attached to. And you want this to be within the thorax. If it's actually, I've seen these not far enough, and if the sentinel tube is outside of the thorax, it's going to cause problems for your chest tube and actually lead to subcutaneous emphysema that you sometimes see associated with chest tubes. So this actually looks pretty normal, and this is just all going posterior to the lung, basically. This particular chest tube. All right, this is sort of hard to see. I apologize, but we're going into the central line world now. And this is kind of where that line goes. 29% said yes, and 71% said no. And I would say no, but I placed this line. Actually, no, I didn't place this line. The resident placed this line, but I was there for the line placement, and it went great. He did an awesome job, and they used the ultrasound, and it looked like it was in the vein. And it turned out this patient had a left-sided superior vena cava, which is a rare anomaly that you see in about maybe 5% of the population or 3 to 5% of the population. And so this actually was in a vein. Um, and we drew blood off it to check a venous blood gas to make sure it wasn't arterial. We checked a CVP, and the pressure was like 5 to 10. So this actually was in a vein, and we did end up using it. But I would definitely be talking to my attending before I would use this line, and we kind of did a troubleshooting. So Andy Lux was my attending, and we ended up publishing this line placement in a journal just to talk about the issues or kind of this anomaly. But yeah, it's going in the wrong direction for a normal patient. Okay, where this PICC line was placed, it's working, but it looks kind of funny. Where is this one going?
We're getting there with the responses.
Awesome.
All right.
It's a curvy SVC, aorta, and azygos vein. Oh, good job, guys. Yes, this is in the azygos vein. And this is a good example of one right here, basically. And you can see it's going through the SVC, and then instead of going right into the right atrium like it should, it goes posteriorly, which is the direction the azygos vein is entering the SVC, and then dips down here. So you could potentially give meds through this, but I would recommend moving that back because the SVC, anytime you have a line like this in a pretty small vein like the azygos vein, there's a risk of clot. A higher risk of clot. I mean, there's a risk of clot pretty much with all of these lines, but like the more narrow the vessel, the higher the risk of clot. So I think we would have to pull this line back so that it still remains in a central vein, but not sort of as high a risk of clot. Okay, so these are just examples of other places that central lines can go, some errant examples. This is a right IJ that ended up going into the right subclavian. I've had this happen to me before. This is a left IJ that goes across kind of this innominate or this brachiocephalic vein, but then goes right up the right IJ. That's also not great. This one actually travels into a vessel, and then it turns earlier and then goes down. This is actually in the aorta. So this is definitely one you want to call vascular surgery about because that's in an artery and not a vein. Generally, though, you want the line to end up right around here. So it'll go in the right IJ and then go right down, end up here. And this is the cavo-atrial junction. It's generally two vertebral bodies below the carina. I usually think about it where this right hard border kind of meets the right main stem, or where the right hard border kind of meets the mediastinum, basically. Kind of you can see that curve. So this is sort of the ideal position. Probably anywhere from the carina to this position is fine. Below there, it may not be a problem, but in some patients do end up developing arrhythmias if it's too low. But some dialysis lines we sometimes want to be pretty deep into this, at least this deep, because the deeper you get into the SVC and even into a little bit into the right atrium, you get better blood flow. And if you have better blood flow, then you can do higher rate of dialysis, and you don't get clotted dialysis circuits. Okay. All right. So last night, one of the nocturnists, who are all great, and I was a nocturnist once, attempted the subclavian but couldn't access the vessel. Which side did they try on?
Okay, we're getting some responses. Here you go.
Right, 42% said left and 58% said right. Yeah, a, a good one. I think that I see this line here. I think this is a pneumothorax, where the pneumothorax is here, and this is the parenchyma. Um, so here, I think you could be fooled, and we'll talk. This looks a little deep sulcusy, and we'll talk about the deep sulcus sign a little bit later. But I think this is the pneumothorax for this particular patient. And there's not lung markings there, but I admit this one's actually kind of hard. This is another one.
Sorry, hang on. My
That's okay.
poll disappeared. Okay.
Yeah, this is another tough one.
Okay.
Okay, 85% said left and 15% said right. Excellent. So yeah, I would agree that it's the left. So, and this is the teaching point I wanted to make about pneumothoraces versus skin folds, and that's pretty tough to sort out sometimes. So a skin fold is you'll sometimes see patients when they're lying on something and they move the plate in, they shift their kind of skin folds around. Usually a skin fold, which is what we see here, I think, will look like kind of white and then a black line and then white after it. So a black line in the middle, but there's still sort of lung parenchyma behind, further beyond it. So it's sort of white, black, white is skin fold. Whereas here you see dark, white, dark, and that's sort of more suggestive of a pneumothorax. And if I go back to this one, I would say right here we see sort of dark, this white line, and then dark behind it. So that's why this is that pneumothorax on the left side. Um, and this is another one, I think, another example of how the skin folds can be really kind of tricky. Like this is, I think, a skin fold here where you see white, a dark line, and then white. So that this is that deep sulcus sign, right? So um, this patient has a really good inspiratory result, right? But it's basically very hypolucent down here. And when it dips like that and the patient is lying flat, that is sort of where air collects when they have a pneumothorax. In this sort of anteriorly, this is where the air collects. So this is again why you want to make sure you know if the patient's sitting upright or supine. It really makes a difference in pleural effusions and pneumothoraces. Because when we sit the patient back up, then you see this one is a really nice crisp pneumothorax line here with a dark white dark here. Um, so that's just supine or upright versus supine, kind of the deep sulcus sign. So you'll see kind of it basically looks like the left hemidiaphragm that's just much more kind of dramatic looking than normal. Here's another example where you just don't see air that far down basically when you're looking at chest x-rays. So this is another kind of pneumothorax where the patient's lying flat. And so it's collecting here. And then if the patient's set up, then you would see it up here. Okay, so tube line verifications, just to summarize, the endotracheal tube should be 2 to 5 centimeters above the carina. The chest tube side hole should be within the thorax or the sentinel ports. Feeding tubes don't change direction until after the diaphragm. Central line should end in the cavoatrial junction. Pneumothorax can manifest as a deep sulcus sign in supine patients. And that's pretty much it. To summarize, make sure you have a good quality chest x-ray and you're looking at the rotation, inspiratory result, the positioning, and whether or not the exposure of the film. And then using a systematic approach, the ABCDEF1 is the one I usually use. I've had actually met other people who use from the center of the film outward. So they look at the trachea and the spine first, then they look at the mediastinal structures, then they look at the heart borders, then they look at the lungs, then they look at the ribs. That's another. But as long as you use some system, I think this is probably the best, easiest to remember one. The silhouette signs help you localize opacities. So when you lose a crisp border, usually something is going on there. And then tubes, lines, and drains have typical courses that you want to make sure that they're following when you're verifying placement. So yeah, I think that's all I have. Any questions?
Yeah, feel free to unmute yourself or throw them in the chat. That was awesome. Thank you so much. I feel like a whirlwind review of lots of things.
Yeah, so sorry. And the thing is, like, there's just so much more, honestly. One thing I should have mentioned earlier, somewhere in here is I mentioned there's a primer, a chest X-ray primer that Julie Takasugi, one of the former radiologists at the VA, wrote, and Andy Lux wrote. That's located somewhere on the internal medicine interweb as like a tutorial under a tutorial or teaching sessions, and that's excellent. It's like a 200 slide thing that like if you could really dive in, but it does allow you to jump from section to section. Say if you just want to look at parenchymal abnormalities, or if you just want to look at pleural abnormalities, you can jump from section to section. So that is I have a link to that in this slide set, but maybe I can put it in the chat as well. But thank you.
Yeah, thanks. Any questions from our party rooms? Okay, we've got a clap. Thank you, Harborview. Much appreciated. 2 claps. 3 of all 3 claps. Okay, awesome. Thanks, you guys. Ooh, and rockets. Okay, it's gonna be fun.
Thank you so much, guys. I appreciate it. This is fun.
Yeah. Okay, I'll see everyone next week. And yeah, thank you again. We really appreciate it.
Bye-bye.
Night.